Okay. Yeah. Good morning, everyone. Today I'm introducing Dr. Lee-Anne Godinho. She's a physician in private practice at Mediclinic Midstream, where she's been serving since 2018. With a strong passion for internal medicine and critical care, she is deeply committed to advancing patient care through both clinical practice and leadership. She is an active member of the hospital's Clinical Performance Committee, representing the ICU, and played a pivotal role in the developing and implementing ICU protocols to ensure evidence-based standard care. Dr. Godinho has a particular interest in antimicrobial stewardship, promoting responsible and effective use of antibiotics to combat resistance. She is also the chairwoman of Sanocare Brief of Hope podcast and clinical governance. She serves as an executive member of Sanocare, where she continues to champion innovation, medical excellence, and patient-centered care. Thank you so much, Lee-Anne. We're looking forward to your presentation.
Thank you so much for the kind introduction. Today I'll be discussing iron deficiency anemia. And when preparing these topics, I like to choose something that sort of applies to all levels, and it's something that is common and quite practical. I mean, we're all seeing this kind of on a daily basis. So just a quick overview. I'm just going to explain or recap iron metabolism, and then I'm going to talk about what affects the intake and the absorption of iron, what then affects iron loss, which essentially leads to the iron deficiency. What do we see clinically and in the laboratory with iron deficiency? What investigations are recommended? And then the current treatment recommendations. And if we have time, I have a short case study as well. So basically, if we can recap, the image is a little bit blurry, but basically how it happens is iron enters the small intestine in the form of either heme iron or non-heme iron. 70% of the iron will be in the non-heme form, and it is converted from the ferric form, which is Fe3+, to the ferrous form, Fe2+, by the duodenal cytochrome B. It then will enter into the enterocyte through divalent metal transporter 1. And from there, on the basolateral membrane, it will be transported via ferroportin 1 into the circulation. And there, basically, it is converted back into the ferric form, and two ferric molecules will actually bind to transferrin. Transferrin is produced by the hepatocytes. It transports the iron. The half-life of it is about 8 days, and it will increase with iron deficiency. Higher levels are also found at higher altitudes and are associated with a higher risk of thromboembolism due to the potentiating effect on prothrombotic factors. So hepcidin inhibits ferroportin 1. So if there's excessive iron, that transporter will be blocked. Iron will remain within the enterocyte and form ferritin or hemosiderin, and these enterocytes are sloughed off every 3 days or so, and iron is lost in that way. So what is ferritin? Ferritin is really the storage protein for iron. It's a large molecule. It's got heavy and light chains. And much of the ferritin is actually accessible for your metabolic needs. It is degraded by lysozymes through a process called ferritinophagy, which is a process that is important in actually recovering intracellular iron when it's needed. And then when this ferritin actually accumulates, it will aggregate and is proteolyzed by lysozymes to form hemosiderin. Hemosiderin will release iron, but more slowly, And just to mention, on a bone marrow aspirate, this can be seen with Russian blue staining. There you go. So your body iron content, it's the stored component, which is ferritin and hemosiderin. And then the rest will be as part of hemoglobin in the red blood cells, as well as the developing erythroblasts, which is 2 to 2.5 grams. Then you get the iron that is bound to the transferrin, which is about 3 to 4 milligrams. And then iron is also found in other iron-containing proteins, such as myoglobin. And that consists of about 300 to 400 milligrams. Sorry, just wanted to mention only about 1 to 2 milligram is lost by the desquamation that I spoke of. So a normal Western diet will contain about 15 milligrams of iron per day. And as I mentioned, 30% will be heme iron and enters the enterocyte via the heme transporter, and the rest will be non-heme iron. And this is actually, the absorption of this is increased during iron deficient states. So one of the factors that actually affects the absorption of iron, the heme iron is more readily absorbed, but the non-heme iron, there's various factors that either will increase or decrease the absorption of the non-heme iron. So meat and fish or things that contain heme iron will actually also promote the absorption of non-heme iron. And then vitamin C will increase the absorption, which is why we often give vitamin C together with an iron supplement. Things that actually negatively impacted are things like medication, proton pump inhibitors, phytates, which is in brown oats and rye, polyphenols, which is in tea, and soy protein. So that's a bit of a double whammy for a vegetarian, because maybe they're not, taking in much iron in the heme form. And then what they're taking in non-heme form, they're often taking with soy protein, which will reduce its absorption. So when you request an iron studies from the laboratory, it will always give you a transferrin saturation. And this is measured or can be calculated. So when calculated, it is the iron over the total iron binding capacity, and it's given as a percentage. So normal is about a third, and disorders that cause reduced transferrin saturation would be iron deficiency, anemia of chronic disease, and then also some genetic variants. So as I mentioned, you get some normal iron losses. Skin, sweat and skin cells and sloughing of enterocytes will cause a small amount of iron loss, as well as menstruation. And 20 to 30 milligrams per day is released by macrophages from the breakdown of old senescent red blood cells. So what would be considered an abnormal loss of iron? It really boils down to gastrointestinal and gynecological blood loss. So excessive menstruation, menorrhagia will cause excessive iron loss. Anything that causes a hemorrhage from anywhere, but it's usually from the GIT, will cause iron deficiency. Surgery as well, and then anything that results in hematemesis or melena, so gastritis or peptic ulcer disease. So hiatus hernia can also cause iron deficiency anemia, and this, you do not necessarily have to have melena stools or see the blood in order for it to cause iron deficiency. It causes linear erosions that will actually result in small hemorrhages that you might be completely unaware of. Hematoschisia, which is blood in the stool, can be caused by hemorrhoids, hemorrhoidal bleeding. Pregnancy and delivery, the demand for iron goes up significantly during pregnancy, and during the delivery, there's significant blood loss. Hemoptysis, hematuria, and then bleeding disorders like von Willebrand factor. So occult bleeding is usually of GIT origin as well. So you can have a malignancy, you can have angiodysplasia in the gut, gastritis, as I mentioned, and then, sorry, there's a spelling error. Telangiectasia of the gut can also result in it. Intestinal parasites like worms, hemodialysis, and then you get urinary and pulmonary hemosiderosis. So urinary is when you have chronic intravascular hemolysis with hemosiderin accumulation in the bladder, and then the epithelial cells of the bladder are then lost. An example of this would be in a prosthetic heart valve, where you have hemolysis, PNH, and intense athletic training, where I think you call it March hemoglobinuria, where the impact of the feet from the running cause hemolysis. And then pulmonary in diffuse alveolar hemorrhage and idiopathic pulmonary hemosiderosis, iron is lost in the alveolar and bronchial epithelial cells. So what causes abnormal intake or absorption of the iron? Reduced intake, as I mentioned, vegetarians or vegans may not take in enough. And then certain diseases and disorders can cause impaired iron absorption. Celiac disease, bariatric surgery or gastrectomy. As I said, PPI use, NSAIDs and anticoagulant use, because both of those will predispose to GIT bleeding and ulceration. Atrophic gastritis, which is autoimmune. Helicobacter pylori infection, and then you get what is called refractory iron deficiency anemia, which is a genetic disorder where there's increased hepcidin levels. So focusing on the iron deficiency specifically, it really is a very common disorder. It affects a large proportion of the world's population, especially women of childbearing age, children, and then individuals in low to middle income countries. To take note and understand is that you can have iron deficiency without anemia, which is called non-anemic iron deficiency. I'll explain to you how this progresses. So who most commonly, as I said, menstruating women. There was this retrospective cohort of 640,000 females aged 15 to 54 years, and 38% had iron deficiency. So that's really a lot. Pregnancy, as I said, it increases your need for iron or demand, and then can lead to iron deficiency. Athletes have more commonly have iron deficiency, which is usually various factors that cause this. And then older individuals, again, this is also multifactorial. It's to do with old people having the kind of tea and toast diet, and not taking in enough iron. They may be having atrophic gastritis, GIT problems, it's not being absorbed. And then once it's identified that they have iron deficiency, they might not want to take their iron supplements if it's worsening their constipation, which is what a lot of old people deal with. Then there are some racial and ethnic disparities in the data that I read was from America, and it said that the most common was in Hispanics, then African Americans, then Asian Americans, and the least in Caucasians. Blood donors also have iron deficiency more frequently, which is pretty self-explanatory. So how does iron, deplete, and how does it become a progressive disorder? So initially, all of the iron stores can be depleted through losses, and or a combination of reduced intake. And at this stage, you may not have any anemia. In these patients, you will see that the ferritin, the stores, are reduced. The transferrin saturation is, I should say, decreased, I think. Yeah, that's an error. Transferrin saturation is decreased, and the total iron binding capacity is also decreased. Is increased. So that transferrin, sorry, I'm confusing everybody, but the ferritin, which is the stores, will be low. The amount of iron attached to transferrin will also be low. So transferrin saturation is low, and the total iron binding capacity is increased. There will still be iron available if the stores are depleted due to the pool of iron that is released from your red cell turnover. But eventually, the bone marrow will start producing iron-deficient red cells. Initially, these cells might still be normochromic, or normocytic, but later they will become microcytic and hyperchromic. Just a reminder that you could have more than one deficiency or nutritional deficiency, especially if the problem is absorption. And then if it's something like a vitamin B12 deficiency, which causes macrocytosis, your microcytosis of iron deficiency will be obscured. So just to mention, you do get true iron deficiency, and then you get functional iron deficiency. The concept of functional iron deficiency just tells you iron is there, but it is not necessarily available for the red blood cell production. That would be a functional iron deficiency. So one case in which it happens is we have iron available, but the release into the circulation is not rapid enough to support the increase in erythropoiesis. And that's what you see in patients with chronic kidney disease, where they're given EPO, erythropoietin. And then also in anemia of chronic disease or chronic inflammation, there is this block of iron release from the macrophages, resulting in high hepcidin levels. And just an example is malignancies, autoimmune disease, diabetes. So there is iron, but there's a block. So what are the findings on the laboratory tests? As I said, on your full blood count, which is very helpful in pointing you in the right direction to start looking for an iron deficiency if you haven't done your iron studies yet, you may see a low hemoglobin if they're anemic. You may see a low MCV, a low MCH for the microcytosis and the hypochromia, and a low MCHC. You will see an increased red cell distribution width and a low red blood cell count. Your smear, you can see the hyperchromia, you can see the small cells, the microcytosis, you can see pencil cells like poikilocytes and target cells. If you do see an increased red blood cell count, then you would consider thalassemia as a cause of your microcytosis. Increased platelet count, there's kind of two reasons why you may see this. It's thought to be due to stimulation of the precursors of erythropoietin that can increase your platelet, or it's, as a result of the ongoing bleeding that the patient has, that you have this reactive increase in your platelets. On your iron studies, you see a low ferritin, low transferrin saturation. I do get a lot of phone calls and people pointing at the free iron. It really is not diagnostic and is not the most important test. This is just, the hematologist will better know how this looks, but this is the same picture or same patient, and the bottom one is just a higher magnification, and the cells are small. I think the arrow is pointing at a lymphocyte just to show how small the cells are, and you can also see some of the pencil cells there. Other tests that you can do is your reticulocyte count, which can be low, meaning, there's not enough iron for red blood cell production, but it's non-specific. There'll be other causes that can cause that to be low. So it doesn't tell you specifically about iron. You can also do your soluble transferrin receptor measurement. And it basically is a protein on cell surfaces, specifically bone marrow precursors, and how it's described as grabs transferrin to pull more iron into this cell. So it is increased in iron deficiency. So the higher the soluble transferrin receptor level, the more the cells are demanding iron. The benefit of doing this test is that unlike ferritin, it is not affected by inflammation. Ferritin is an acute phase reactant. So you might see your ferritin being elevated in an inflammatory condition, and it doesn't tell you that the iron stores are low in that particular patient. So red blood cell protoporphyrin and red blood cell zinc protoporphyrin, I'm not aware of whether we have these tests available in South Africa, but basically when you don't have iron, then zinc is incorporated in the protoporphyrin thing, so in developing red blood cells. So if you see the zinc, then it will also tell you that there's an iron deficiency. Another kind of nice test, which I also don't think is available, is the reticulocyte hemoglobin content. It also gives you information about your iron status that is, it's and is not influenced by inflammation, like ferritin. Bone marrow iron standing is really the gold standard for assessing your iron stores you really want to see. So this is kind of a busy table, but it's just gonna, it's just putting kind of what I've said already in table form. So you have the iron deficiency in the first column without the anemia, and then the iron deficiency anemia. So they're more or less the same, except the hemoglobin is normal with no anemia. And then anemia of chronic disease, your MCV may be normal, or it can be low. Your hemoglobin will be low. Your ferritin in those patients may be normal because they have normal iron stores, or it may be high from the inflammation and chronic disease that they have. Thalassemia, you're really expecting everything to be normal, except that you have this severe microcytosis, which is very low for the degree of anemia that you can be seeing, although your hemoglobin can also be normal. That's in thalassemia minor. So this, I think we all learn in medical school, the symptoms of iron deficiency. Fatigue, exercise intolerance. Patients can have headaches, hair loss, pica, which is the desire or compulsion to eat substances that are not food. There's various different names. Ice is known as pagophagia. Chalk soil is geophagia, but it's commonly things like that, ash or charcoal or even starches that the patients might crave. There can be irritability and mood changes and actually reduced cognitive function. It's a type of brain fog. You can have restless leg syndrome, and then just to remember if there's you will have all the other symptoms of anemia, and you can have hearing loss. It's interesting. The signs, pallor, dry skin, angular cheilitis, atrophic glossitis, and then spoon-shaped nails, which is the picture there, which is koilonychia. Alopecia, as I mentioned, the hair loss, and then the sclerosis, which is a pale, faintly green complexion, which I think is difficult to identify and is actually very rare. So it's just to know. Okay, so moving on to the treatment, there are two important aspects. You want to replenish your iron stores, but you also want to find the source of the bleeding or iron loss, because otherwise you are pouring the iron in and it will just be lost and your problem won't be resolved long term. So who should actually receive treatment for iron deficiency? Should every single person receive treatment if you find the iron to be low? And the answer is actually yes. All patients with anemia will need treatment, but also patients with iron deficiency alone should receive the iron treatment, even if they have no symptoms, because like I mentioned, it will be progressive. And if you have a deficiency, your diet, what you take in the diet, is not going to be sufficient. So you will continue to have loss. You need supplement in addition to that. So as I mentioned previously, the cause of the iron deficiency should be addressed, whether the most common being menstrual and GIT. When should an endoscopy be done? When should the patient get a gastroscopy? Obviously, in overt GIT bleeding, you want to go in and see if you can achieve stasis, but unidentified source of bleeding, especially if the patient is above 50 years and non-menstruating, you want to do a gastroscopy, and not only a gastroscopy, you also want to do a colonoscopy. So you need to, and that's because of the risk of malignancy going up. So you want to make sure there's not a colon cancer. What treatment should be given? As I mentioned, dietary iron is really unlikely to be sufficient once there is an iron deficiency. You can use diet as a supportive strategy to try and boost the iron, but it's never going to be enough alone. You may need to give the patient a red blood cell transfusion, but this is really in patients with a very low hemoglobin, or if they're having very severe symptoms or hemodynamic compromise. And then you can expect in each unit of 300 moles of blood to contain about 200 milligrams of iron in the form of hemoglobin. So then we know we get oral supplements, and we get iron that can be given intravenously, and you need to choose wisely, otherwise you're not going to be effective in your management. So there's really a lot of factors to take into account, but the concept, the principle is that if the oral iron is not going to be tolerated or is not going to be absorbed, then it's going to serve no purpose, and you need to do IV iron. In any of the conditions on the left there, it's like I highlighted, irritable bowel disease. There may be loss of iron through bleeding, ulceration, but there may also be decreased absorption. Gastrectomy, bariatric surgery, and if you want to correct your iron quickly, or you want your hemoglobin to recover quickly, for example, somebody who's going for surgery in 2 months or less, that person is going to have blood loss during the surgery, and you want to optimize them before, you may choose to use IV iron in those patients. Dialysis-dependent chronic kidney disease, you may also need to give them IV iron infusion. And the pregnancy in the 2nd and 3rd trimester, again, you're trying to optimize them before delivery, because you're anticipating blood loss during delivery. And in those cases, you want to also replenish your stores more rapidly. Older individuals, as I said, there's various reasons why oral iron may not be taken up or tolerated by them. So you would opt for IV iron. And in the case of lack of response to treatment, I'll also discuss that just now, malabsorption and severe ongoing chronic blood loss. So in those patients as well, you want to be more effective. Unfortunately, I've got it in the red block there. Cost is a factor. Oral tablets are a lot more cheaper than the IV iron, and it's not always an option, but unfortunately does also impact on our decision. So the administration of oral iron, there's really been a paradigm shift in how we give it. Several studies have shown that excessive iron dosing will reduce absorption and it will increase your side effects. So myself included, I used to think or think that if this is a severe iron deficiency, that maybe you should be giving your iron supplements twice a day and double dose or something. And in the end, it's completely counterproductive. You actually have less iron absorption and you're less likely for the patient to actually take it because they're experiencing severe side effects. So these different dosing regimens that are acceptable, generally you can give iron once a day if it's tolerated, or you can even cut down to every other day or opt for a Monday, Wednesday, Friday regime because they are as effective as daily and are more likely to be taken with less side effects. You get multiple over-the-counter preparations, and basically they are all effective as long as they are taken. So amount of iron you should be given per dose is 1 tablet, so whatever that might be. Any preparation can be used, and they will all have slightly different elemental iron content. But it shouldn't be, you do not necessarily want to go for the higher dose of elemental iron to be more effective. You might go for a preparation that is more likely to have less GIT side effects in one of your patients, and you're going to be more successful with that. What should be avoided though is enteric coated or slow release preparations, as from these preparations, the iron is actually released too far along in the GIT to be absorbed effectively. So you do also get heme iron products. I'm not aware of the ones if there's any in South Africa, but they tend to be more expensive and not superior, so not worth it. The side effects that I've already alluded to are predominantly gastrointestinal. You can have just GIT discomfort, flatulence, like bloating, diarrhea, and constipation, black or green tarry stools. You can have nausea and vomiting and metallic taste. So how long should you give your iron if you've decided that this patient should recover on oral iron? How long should your duration be? It really differs according to various experts, but it can take 6 to 8 weeks for anemia to resolve, and it can take up to 6 months to replenish your iron stores completely. So this is a little bit repetitive, but the advice that you're going to give your patients, heme-containing foods will increase the absorption. Coffee, oxalates, tannins, in teas and that, and calciums and phytates, all of them will reduce the absorption. So you're not going to take your iron with a swig of tea. And PPIs, you're going to look at whether the patients are on them. Do they actually need to continue them? It takes about 6 weeks for a gastric ulcer to heal. Maybe after 6 weeks, you can stop and your absorption will be improved. Antacids, if the patient are on them, they have to take them 2 hours before or 4 hours after the iron supplement. And if they can, they should take it with a bit of vitamin C, like orange juice. Again, you can improve the tolerability by relaxing with your dosing, perhaps going for alternative days, and you might want to give a laxative or stool softener if you think it's going to help the patient. So moving on to the intravenous iron infusion, there are really a number of IV formulations available, not as many as there are oral preparations. They are all equally effective, all have similar safety profiles in the second and third trimester of pregnancies. So what would really affect, influence your choice of which one to use is the cost, what the medical aid may cover, the duration of the infusion, and the number of visits or infusions that might be required to reach your target ferritin. The side effects of IV iron, some are not serious, it's a bit of metallic taste. There can be some nausea, vomiting, and a bit of abdominal cramping. They can have an arthralgia or a muscle ache, myalgia from it. But the more serious side effects are hypersensitivity reactions that, vary. It ranges from hives all the way up to bronchospasm, anaphylaxis. And you can also have hypophosphatemia. So pre-meds, giving an antihistamine or something before you give iron is not recommended because often that has been found to worsen your side effects, or then you have hypertension from your antihistamine and you won't know, is it from the antihistamine or the iron? So there's really no benefit. Test doses are not necessary with all of the newer agents due to improved safety, but there are, I'll get to them. You can give methylprednisolone, just 125 milligrams IVI stat. If you're thinking that this patient has already got an inflammatory arthritis and you want to help with that, you want to prevent side effects, or in somebody that you really think has an increased risk of having a hypersensitivity reaction, you might preempt it. So with mild reactions, as I mentioned, there's no hypotension, there's no tachycardia, there's no bronchospasm. Antihistamines and other medications are really still to be avoided. If they're having a bit of nausea and it's persisting, you can administer methylprednisolone and wait for 30 minutes and restart your iron infusion. And you can even continue an oral course of corticosteroids if you think it's going to help. But severe reactions can be very dangerous, and you should manage them as anaphylaxis. Iron is given intravenously. It should not be given transdermal, subcut, or intramuscularly. There is this theoretical risk of infection, but that certain microorganisms require iron or thrive with an increased iron. But really, this is negligible, and if you do a risk-benefit, the patient might benefit from treating the iron deficiency than actually worrying about a potential infection. So the dose of your IV iron is, you can calculate it based on the package insert. It will tell you. It will take into account things like body weight, current HB, what HB are you trying to reach, and the iron stores. So these are the main 4 ones that we have here: Ferinject, Monofer, Cosmofer, Vinifer. And so you can see the doses vary, if you're not calculating specific to a specific hemoglobin, you can follow those guidelines. And the infusion times are different depending on the dose that you're giving. The general idea is if you're giving a higher dose, you rather infuse it slowly. If you're giving iron for the first time, you're obviously going to be a lot more cautious, and you might even opt to go slower. If just to take note, Cosmofer is a test dose should always be given. And the infusion time to give larger doses of the Cosmofer, or they're also much longer, the recommended times. And Venofer, they actually do not, it's not required to give a test dose, but it is recommended if you're thinking the patient has a possibility of having a reaction. So how quickly do I feel better? That's what patients always ask me. And basically the PICA, you get immediate resolution, and everything else is fairly quickly. You get improvements in their general well-being, feeling better within days. The restless legs can resolve within 3 days. And moderate to severe anemia, you will have reticulocytosis within 7 to 10 days. After 2 weeks, the hemoglobin will then start to rise. And then over the following 3 weeks, you will get normalizing of your hemoglobin, the real increase leading to a normalization after 6 to 8 weeks. So when I was reading about this, I was a little bit surprised by some of the recommendations for the follow-up. I did not realize that such short periods would be recommended. But obviously, if it is a really severe anemia that you're dealing with, then you want to keep a close eye on it. If they're on oral iron, you want to review after 2 weeks with a retic count and an HB. And you want to check in and find out if they are tolerating it. IV iron, the review is much longer, 4 to 8 weeks. There's no purpose in doing the iron studies within 4 weeks, as you know, the what you have given is going to influence the results of that. And then iron should really be given until the ferritin and the transferrin saturation normalize. So you want to get your stores to be normalized. What if the iron stores are still not normalizing? What are the questions that you should be asking yourself? So maybe the patient's not taking the iron due to side effects. Maybe there's reduced absorption of oral iron, which you initially underestimated. Maybe your blood loss is exceeds the iron intake, so you're constantly on a negative, or you had an incorrect initial diagnosis, or there's more than one diagnosis. So maybe you're dealing with another nutritional deficiency, and in those patients, your iron might be improving, but your hemoglobin is not improving. And then iron therapy is effective, but you've got this ongoing loss. And in those patients, it becomes important to screen for celiac disease, Helicobacter, and then possible autoimmune gastritis. I'm not going to go through this, but just knowing who is at high risk for iron deficiency, those are the people you need to be screening. And you can do an FBC ferritin, keeping in mind you don't want to do this. A ferritin can sometimes be misleading. So I wanted to discuss this case study that I saw at the beginning of this year. It was a 17-year-old female. She presented with a history of fatigue, dizziness, and syncope. She's a girl who is homeschooled. And she is not a vegetarian, but she doesn't really enjoy red meat. What she does love is tea. And she, on further questioning, she basically sits and drinks tea all long. Several cups, 6 to 8 cups a day. So what made her interesting also is that she said, look, from the get-go, don't put me on things because I don't want to swallow tablets, and I can't because I feel like I want to gag when I'm swallowing tablets. She is a young female, but she had no history of menorrhagia. And she had no symptoms of reflux, gastritis, or obvious sources of bleeding. And if you look at, this is her blood results, if you just ignore the right-hand side and look at the left column with the results, on the left-hand side, you see it's in December of 2024. She had an anemia, HB of 9.9, low hematocrit. MCV was low, 76.3, and MCH was 22.6, also low. And this is what her iron studies looked like. Her iron was low, 3.5. Transferrin was 3.9 high. Transferrin saturation was low. Her ferritin was 1. So she had quite a severe iron deficiency anemia. So what other investigations were done? She had a syncope workup because it was really one of her predominant symptoms and a reason why she wasn't active or doing much. The vitamin B12 was normal. Her vitamin D levels were also fairly low, 13.1. The rest of her routine bloods were normal. In her workup, she had a gastroscopy done, and it indicated esophagitis and gastritis, although she was negative for Helicobacter pylori. So how was she treated? While in hospital, which I haven't put there, she received IV Monofer, 1.5 grams. And then in her, what I treated her with was with low-sec MAPs. That's a PPI. But basically in each capsule has these little dispersible pellets. So it can be dissolved in water. And she was on that for 6 weeks. And she also received Quadrifer, which is an iron, over-the-counter iron preparation, but it's a dispersible powder. And then she also got her vitamin D drops as a liquid. She needed quite a lot of that, about 1 ml per day to get to what we wanted to give her. So she was advised to reduce her intake of tea and try to incorporate more iron into her diet, and advised to really get outside and start getting more active once she was feeling better. And just to go back, on the right-hand column, you can see there is her iron supplementation treatment started somewhere in January, and those bloods are from May, and her ferritin actually recovered quite nicely to 92. Everything looked, her anemia resolved, the hemoglobin to 13.8. The only thing that was a struggle was, which is not on the picture here, was the vitamin D. It only really improved to from 13 to 18. Which is really not a great level. So after that, I actually opted for the 50,000 units of vitamin D, which is a weekly preparation, but it's a small gel. Get it in a small gel capsule. So that was a fairly long presentation. So I just want to give you the quick take-home messages. Iron deficiency, as I said, very common. High-risk individuals are the ones that we should screen. It is important to determine the cause and treat accordingly. And excessive iron given orally is going to be counterproductive because of the side effects and the absorption. And you need to give intravenous iron if absorption is impaired. And you need to monitor your response to treatment. I would say once you stop your iron supplementation, you need to also follow up again to make sure that you're not, there's not a further decline in the iron after you've actually stopped. Thank you. And I just want to mention that certain patients need to be on iron supplements forever. Because, for example, if you have hereditary telangiectasia, or you have angiodysplasia in your gut, you're forever going to be losing, so you always have to.
Thank you, Lee-Anne. This was quite insightful presentation. Going back to a case study, you haven't given us the cost. What do you think caused the anemia? Do you think it's the T?
I didn't.
Do you think it's the vitamin D?
No. So I think it was a combination of things, multifactorial. Her diet was not optimal. She was also she was a young person, but was also a kind of tea and toast person, eating very poorly, not, very thin. She had gastritis and esophagitis, and you lose iron gastritis.
Any link between the T and iron deficiency?
Yes,
okay.
Because whatever you're taking in your food is not to be absorbed, and she is losing in a normal way through menstruation.
This call is not covered by your tariff plan.
Mm-hmm.
So somebody said. So anyway, I think there's a very direct link between actual black tea and iron absorption.
Yes.
So I think they produce something called tea something that actually bind the iron and make it available for things. So that I think probably a very good observation. Yeah, especially people from JCC, I think they normally tend to have a lot of teas that they drink, especially one in the church, and they tend to have quite a significant iron deficiency anemia. So I think the black tea, with the iron absorption, it's a bit of problems and depend what you're eating. And then, so the next question, you really highlight a lot of beautiful presentation. I think if you're a medical student, that's really, you read that, you should get your distinction straightforward. Iron deficiency and pancytopenia, can they present with pancytopenia? Michelle, can
There's journals. It's a rare cause, but it can cause pancytopenia.
So they can present pancytopenia without platelets.
Yes.
And then all the cell lines are down also can really present with that. And sometimes those patients have been, they got a nasal bone marrow and everything when the iron is actually really low. Also, that's one of the trick. And then vitamin D and
If you want to check your B12.
Yes.
Yeah.
What about vitamin D? Any link?
Link.
Because it's also deficient, that obviously.
Well, no, but if your absorption is not great of iron, your vitamin D is often also not. So people with inflammatory bowel disease, they often have a deficiency as well. So they turn off directly, but indirectly linked.
But vitamin D also is not it's really play a lot of inflammation. So if your vitamin D levels too low, your inflammation levels increase high. So perhaps that might give you, I don't know whether that increase your phagocytic of your iron. I'm not so sure, but I think probably there's a role of that. I don't know whether it's iron deficiency or iron block, difficult to say, but I think there's a role. I know vitamin D is an inflammatory in the lung condition. Play quite a key role. So.
The bottom line is if you have one nutritional deficiency, to always check if you don't have others like folate, and vitamin D and B12, because if there is an absorption problem, you can have multiple.
Yeah, and then just last comment from me is that I think every male who had iron deficiency and anemia, they quite extensive workup from head to toe. It's very abnormal for males, while for females, I think you have to really consider their that you consider periods as the first one of the loss. You need to really do a proper gynae history and perhaps extensive workup for female when they start after menopause, I think. Yeah, but I think again, iron deficiency anemia, I also say that it's a marker for underlying malignancy. So again, replacing it in the context, people should not be taking iron supplement if they don't need it. The reason that because it can be a marker of underlying cancer that sometimes present iron deficiency trigger a lot of investigation. Then they might actually find other underlying process that causes it. So it's better to know what cost it than actually taking supplement because you don't know. We have a patient that went to a GP and then had iron deficiency anemia. She was put on iron drip treatment for about 6 months down the line, and then the iron never went up. When the patient was sent, she was having colon cancer. So again, that could have been picked up early. So I think anybody above age of 45, 50, as Lee-Anne has alluded to it, please, those patients need to, first thing is work up, not to supplement and replace the iron. Find the cause and then you treat, because otherwise you're treating something you don't know. So I think it's very important. That would be my take-off message. But otherwise, really a good presentation, and you will get it from our podcast. Any questions? Add on?
I just wanted to throw in a clinical scenario. You've got a patient with recently diagnosed with TB and iron deficiency. What are you going to do?
TB and iron deficiency. Okay, so
On the severity of the iron deficiency, and if it's not supplemented.
no,
No,
treat TB first.
yeah.
So that would be what the approach would be to treat them first, especially the initiation phase.
Yeah.
Also, iron absorption is reduced during that period. So it wouldn't help supplementing that patient either, because the iron absorption due to the inflammation is
Okay.
reduced.
Yeah, so you're focusing on the TB treatment,
Yes.
and then you can just
Yes.
treat the iron again.
And then
And then you're
Supplement.
going to supplement.
Okay, so it's like the iron's been locked up
When
in the freezer. And you,
the intensive phase.
yeah, intensive
that's
absorption. has-
even 3 months.
Yeah.
What do you mean to be 5? What makes me 5?
Well, then you transfuse the patient.
Okay, great.
Because
Somebody
the absorption
online
also
Any question online?
0.8%.
Yes, morning. Thank you so much for the wonderful presentation. This is Dr. Mabuza. I'm a chemical pathologist. I just want to ask a question. There's a study that was done from Stellenbosch where they actually looked at like apparently healthy population, and they found such a high incidence of iron deficiency in healthy young people. And one of the recommendations made was that perhaps patients, or actually individuals, when they see a practitioner, there should be an opportunity there to just do an annual, maybe serum ferritin, just to check, because you don't want to wait till patients have hematological manifestations, because that's really like the last
Yeah.
stage. So what is the feeling in the room about just, especially females of reproductive age, just giving them at the point of contact? They might not be complaining about anything alluding to iron deficiency, but just also checking just the serum ferritin and making it an annual thing so that you catch them early.
Absolutely. I think the thing with iron deficiency also, it sometimes develops over a very long period. This person does not even know that they are fatigued. They have forgotten what it feels like to have normal iron stores. So they might not complain of anything. So I do think it is your opportunity when you see them as part of your routine check, just to see, do they not have iron deficiency? We know who's at risk, but basically it's such a high percentage that basically every female, I feel like, needs to be checked.
I think I absolutely agree with Dr. Godinho in the fact that, I mean, every female will have some degree of low iron. And I think probably most of it also depends on which society you come from. If you come from a low income society, sometimes the food that they eat is not well fortified with the iron. And that means their iron's consumption is not good enough. And I think that's really need to be supplemented, as early as possible. And I was met about Jehovah's Witness patient that came, and then she was having low iron. And I couldn't understand, that Jehovah's Witness, every patient should be having iron tests, because you never know when they need surgery, especially female reproductive action. Yeah, exactly. So I think there's a really very valid, and I think we should be actually looking at them. And I think probably, especially on the general practitioner level, they should be testing those as routine as possible. Every female deserves that test, at least if the first is okay. I remember when I was at University of Pretoria, Prof. Kerr always say, when you have somebody who got iron deficiency, anemia, how long they supplement, he always says supplement for 18 months. I agree. That's what I remember that he told when I was in medical school. That was 3 years ago. Obviously, we need to look at the current data, what it actually say. But I think it's very important that we should consider supplements quite a bit as early as possible, and especially the female that have the heavy periods, those who are, play a great role in sports, athletes, and everything. So I think those, and I remember that Michelle also did present very nice presentation about sports, iron deficiency in sports. I think there are quite a lot of times. So we have a lot of presentation, and we really an advocate for iron supplements. We really go for it, and I think let's make a difference, you know. And then
maybe sometimes they are not checked. Only in pregnancy somebody checks, but even in pregnancy, it sounds, you know, we're all taught you need to take prenatal vitamins or iron supplements or whatever. But I mean, an iron deficiency in pregnancy has actually got a poorer outcome.
Yeah.
So it's very important.
but also remember that I think there's quite some studies which was done. I remember when I was at California, I did my pediatrics internship, and I presented paper, I think, to one of the Prof. Kruger, I remember very well in California. And actually, there's also a direct link between iron deficiency anemia and also children development of their mental capacity and I think their mathematical ability or analytic ability get impaired because of the iron deficiency. So I think children, pediatric population also, we need to be looking for iron deficiency. And I think, again, they need to be supplemented, and most of the diagnosis need to be made earlier. I think probably from the time that the child is born, we need to be looking at this, you know, because it doesn't mean that the child is healthy. You must just put your hands up saying, okay, all is okay. It's like planting a tree in the bush and hoping that it grow and become, produce enough fruits. No, we should be able to be visual looking for it as a healthcare professional.
Yeah, also just also, I did a course, the patient blood management course, and there I actually that private practice the incidence of deficiency, and it's also about 30 to 40%. That's a population that's got well educated, well fed people. So, and the increase in risk is actually like your children under 5, your pregnant or not your pregnant, but your population that can get pregnant, so your young females. So it's very important to screen them, because the other thing is, if you do get pregnant, you got your increased risk of worsening your iron deficiency. So it's best to prevent it before pregnancy. As you see, Lee-Anne mentioned, iron transfusion is actually contraindicated first trimester of pregnancy. So you'll give oral iron, but the ferritin is elevated in pregnancy. So you won't correct that iron deficiency quickly. And then it increases the risk. And there's studies being shown that there's a higher risk of autism due to iron deficiency in pregnancy. So the main population we need to focus on is preventing iron deficiency before you get pregnant.
Yes.
Thank you.
Yeah.
I've got a couple of questions. So first question is there any specific time that you want to do an iron study? Because we know there's variations, or does it matter or not? And then the problem that we have in hospital is patients come in, you do an iron study, but they've got an underlying chronic infection or an infection going on. So the ferritin is usually raised, so you can't use that.
Yeah.
Do you look at the saturation levels as well? And how long should you then wait before you can repeat the ferritin and see if the patient has iron deficiency? And then the last question that I have is, if a patient is given parenteral iron, like Monofer, right? Is there any point in giving them a discharged oral iron or not? So
Yeah.
I'll leave that to the pathologist as well. So because there is a mechanism. What time? You take it in the morning or evenings? Is it? Does it? Yeah. Well, I understand. Is there any specific
The
time?
iron is affected by the diurnal rhythm.
Yes.
Number one. And then iron can also be affected by recent intake
Yes.
and supplementation. So we normally recommend that you take it fasting.
First thing.
Yes.
Yes, fasting. Yeah. And then what was the other?
So if a patient, if you do it in the mornings, fasting patient, and the patient has lower iron, but with a raised ferritin, can you then, with a low saturation, is it then more indicative of an iron deficiency or?
No, for iron deficiency, remember the marker is ferritin. It's not iron.
Yeah.
It's ferritin. So the one that you have explained now or you described it can go into the category of iron deficiency of inflammation. Yeah, the one that you have.
But how you tell the difference is you can do that soluble
Soluble transferrin receptor. Yes.
That will be,
Yeah.
that will.
Because remember that the patients with chronic anemia of iron deficiency of chronic disease, they may also have functional iron deficiency. So those patients may have a raised ferritin, but they may still need iron because that the iron is blocked. All right. So I think it's very important to diagnose functional iron deficiency because they may still need to be supplemented. And supplementation, they should recommendation would be IV because now the hepcidin will be raised because of inflammation, so they won't be able to reabsorb or to absorb that iron that they're taking.
It looked like our hematology came part, the ups and really getting exciting. The discussion is really beautiful, but unfortunately we don't have time. Thank you for joining us and join us next week. Anybody got the last question? Okay, we'll take the last question.
It's not a question, but I think, is it Dr. Okoli that had a question before me? I just wanted to comment on that. I wanted
Emmanuel?
to comment on
Yes,
the
good morning. Yeah, I wanted to ask a question.
Yes.
Yes, there we go.
Morning, thanks for presenting. No, I just had a clinical scenario. A gentleman who is in his 50s has iron deficiency. Sanocare blood was positive. Did the cancer markers, none came back positive. CT scan also negative. GNC scope didn't pick anything. So ended up doing a red cell scan, which came back to say there's evidence of bleeding in the colon. So where do you go from there? Obviously, the patient wasn't too keen on having another repeat, G scope. They didn't feel quite comfortable. Surgeons recommended capsule endoscopy. Is there any other one can do in such a scenario?
Yeah, I think normally those patients, if it's male, you must look at their history because sometimes there's something called angiodysplasia that could actually have this minute kind of bleeding without you actually seeing a overt kind of bleeding. So those patients normally they have a certain between their vascular part and underlying aortic stenosis, and they could present with that. So normally that's the most commonest thing. The second thing, sometimes they have to do a GI biopsy because sometimes they got what we call microscopic colitis, which you might not see. So that's what we do. And that sometimes then the capsule endoscopy will tell you that the bleeding just from the colon, and then you take it from there and notice that regular disease is special. Yeah. So I think normally angiodysplasia is the most commonest thing that we see on those kind of patients.
Those ones they do something.
Thank you.
Capsule.
Yeah.
A gastroenterologist.
Gastroenterology capsule,
Go to.
Yeah. Video capsule is quite expensive, but I think need to be booking. You need to get authorization, and then the gastroenterologist number can do it for you.
Okay, thank you.
But I mean, you did a bone marrow on them? Because I don't know, the occult stool also cannot be sometimes very sensitive, because the question that I think you must always think laterally, because again, if you have a condition like amyloidosis with gut infiltrates, can that give you also?
And iron deficiency, but then the bone marrow wouldn't.
Might work.
I'd rather do a fasciitis biopsy or something
Okay.
like that.
All right, yeah. Look, I think it's possible to speak to one of the hematologists here. There's Michelle, and then James also is here. So they got Agnes. I think they'll give you feedback. I will post for you their contacts. Okay.
Okay, thanks, Doc.
Okay.
Last question? No?
Thank you so much.
Oh, sorry.
Please join us. Thank you for joining us today. Tomorrow we have an ethic presentation. Dr. Okoli, you must join. Ethic presentation by Prof. Veronica Ickerman. The topic is already on the links in, and then you need to send us your number so they can get allocated to get entry point. I think it will be definitely available. So please join us tomorrow at the same link, the same contact, the same the Teams password remain the same. Join us tomorrow, and if possible, invite more people, and if possible, recruit more people for the presentation on Wednesday and Thursday. Thank you so much, and have a lovely day.
Thank you. Bye-bye.
Thank you.